Acquired bleeding disorders. Pathophysiology. NB. Liver disease causes clotting factor production to become defective and thrombocytopenia is common. The quality of the fibrinogen is often defective. In liver disease there may be vitamin K deficiency, which is associated with jaundice. Factor VII levels can act as an indicator of liver damage in a number of clinical situations, e.g. paracetamol overdose. Vitamin K deficiency related to biliary obstruction, malabsorption, or warfarin overdosage is usually apparent from the history. It will result in a prolongation of the prothrombin time, PT, rather than the activated partial thromboplastin time, APTT, which is less dependent on vitamin K-related factors. Disseminated intravascular coagulation, DIC, results from excess thrombin formation in the presence of suppressed fibrinolysis and physiological anticoagulants, protein C, protein S, and antithrombin 3. Interleukin 6 has been strongly connected with DIC. Major tissue damage or malignancy will cause tissue factor and factor VII to trigger fibrin formation. Protein C and S and antithrombin 3 levels fall due to ongoing coagulation and impaired synthesis. Plasminogen activator inhibitor type I is increased and inhibits fibrinolysis. As DIC progresses, factor levels fall and platelets are consumed within the clot. Fibrinolysis results in rising fibrin degradation products, FDPs, and the consumption of fibrinogen. DIC can be acute and fulminant as seen in major trauma cases, or chronic and subtle as in malignancy and liver disease. NB. The bleeding tendency associated with renal disease is due to poor platelet function rather than an acquired clotting defect. Dialysis will improve platelet function and reduce bleeding. Autoantibodies to clotting factors such as factor VIII and von Willebrand factor, VWF, occur in autoimmune disorders, inflammatory arthritis, malignancy and with certain medications. This produces a severe acquired hemophilia that is often fatal. Finally, any cause of severe thrombocytopenia will produce an acquired bleeding disorder. Bleeding does not usually occur spontaneously until platelet levels fall below 20x109/L. However, bleeding may occur in the presence of a normal platelet count if the platelets have become qualitatively abnormal, e.g. in renal disease, malignancy, and myeloma. Clinical presentation. Acquired bleeding disorders usually present as extensive superficial bruising. Purpura is typically a feature of thrombocytopenia. Mucosal bleeding from gums and throughout the gastrointestinal tract can be torrential. Hematuria is usually due to local causes but can be a feature of acquired bleeding disorders. Joint bleeds are uncommon. DIC may be associated with both bleeding and active thrombosis and infarction, due to platelet deposition, resulting in the failure of all organ systems. Causes of DIC include 1. Sepsis, 2. Trauma, burns, surgery, road traffic accident and fat embolism, 3. Cancer, 4. Obstetric, amniotic embolism and abruption, 5. Transfusion reaction, 6. Vascular abnormalities, Kasabach-Merritt syndrome, 7. Toxins, venom and drugs, 8. Transplant rejection, 9. Liver disease. Investigations. Patients with liver disease are usually easily spotted clinically, and liver function tests confirm the suspicion. However, the coagulation disturbance of liver disease can merge with, and be difficult to distinguish from, DIC. It is usually a matter of degree. Prolongation of the PT and APTT along with a falling fibrinogen level is highly suggestive of DIC. FDPs, in particular D-dimers, indicate that fibrin is being actively broken down and they are raised in DIC. However, perhaps the most sensitive marker for DIC is a rapidly falling platelet count. Protein C and S and antithrombin 3 levels fall. Table 20 will help to distinguish the causes of bleeding. Acquired clotting factor inhibitors produce a very specific and profound fall in an individual clotting factor. This usually prolongs the PT or APTT. Specialized clotting tests will then show that incubation for 2 hours with normal plasma does not correct the abnormality. FBC and blood film may reveal microangiopathic features in DIC. The film may be informative about causes of thrombocytopenia. Management. NB. It is essential to treat the underlying disorder vigorously. In liver disease, intravenous vitamin K should be given over a number of days. Infusion of fresh frozen plasma, FFP, 15 ml/kg, or factor concentrates should be considered if there is bleeding. Further bleeding despite infusion of FFP may be due to defective fibrinogen and require cryoprecipitate. In DIC it is important to replace clotting factors with FFP, aim to restore PT and APTT to within 1.5 times normal, cryoprecipitate, aim to restore fibrinogen to greater than 1.5 g/L, and platelets, aim to restore count to greater than 20x109/L if not bleeding, to greater than 50x109/L if bleeding and to greater than 100x109/L if bleeding in head or eye. Clotting tests should be repeated a few hours after infusion to check if any correction has been produced and further infusions given if necessary. It will not always be possible to correct laboratory results, but clinical bleeding may improve. Watch out for fluid overload. If antithrombin 3 levels are very low, then antithrombin 3 concentrates should be considered. NB. There is no set formula for giving blood products in the presence of massive blood transfusion. Clotting results and clinical bleeding are the best guides. Always seek advice from a hematologist. Acquired clotting factor inhibitors need to be managed in specialist centers. Infusion of porcine factor 8 or factor concentrates to bypass factor 8 deficiency, e.g. factor 8 inhibitor bypassing agent or recombinant factor 7A, may be used. Defects in platelet quality and quantity can be treated with platelet infusions. 1 dose of platelets is equivalent to platelets from 4 individuals. An infusion of 1 dose should produce an increment of about 40x109/L in the platelet count 1 hour after infusion in previously untransfused patients, and should be considered for anybody bleeding with a low platelet count. Patients with platelet levels of less than 20x109/L, due to marrow failure, without bleeding should be given a prophylactic platelet infusion. NB. Always repeat abnormal clotting results in FBCs. Do not overreact to a single abnormal result, it may be false, e.g. a blood clot in the sample tube may produce profound thrombocytopenia.